Have you ever just, watched a child, maybe your own or a niece or nephew, or even just kids playing somewhere, and you're just amazed by how quickly they change? I mean, 1 minute they're this tiny, totally dependent newborn, and then it feels like no time at all. They're walking, talking, they have opinions. It's just so much more than simply getting bigger. It feels like this, incredible, almost magical transformation. Today on the Deep Dive, we're really digging into that whole process. We're talking about the fundamental concepts of child growth and development. Now, we often use those terms, almost interchangeably in daily life. But if you really look at the foundational pediatric research, it's clear they are distinct, very distinct. But they're also deeply interconnected aspects of how a human changes, really from conception all the way through to adulthood. Our goal today is to give you a real shortcut to understanding these complex processes, to give you the kind of deep knowledge that, honestly, elite professionals in this field rely on.
Absolutely. And understanding this isn't just academically interesting. Getting a really nuanced grasp of how children grow and develop is, it's crucial for anyone interested in health, well-being, or even just the amazing journey of human life itself. We're aiming to go beyond just the surface level today. We want to help you really master the underlying biology, the environmental factors, the clinical assessments, and even those subtle signs that tell us if things are on track, or maybe if they're not. This whole deep dive is based on solid evidence-based understanding, and we're here to unpack those key insights for you.
Okay, let's start right there then. We hear growth and development said together all the time, like they're inseparable. But the research says they're distinct. So let's be precise. When we talk about a child, what exactly is growth and what is development?
That's the fundamental starting point, isn't it? Getting those definitions clear. So when we talk about growth, we're specifically referring to a net increase in the size or mass of tissues. Think of it as primarily a quantitative change. It's measurable. This increase happens mostly because cells multiply, that's called hyperplasia, and also because the substance within the cells, the intracellular material, increases. Cells can also get bigger individually, hypertrophy, but that's generally a lesser contributor to overall growth compared to cell multiplication. So when we measure a child getting taller or gaining weight, we're observing growth. It's about the physical dimensions, the mass, getting bigger, heavier.
Quantitative. Okay, that makes sense. More cells, more stuff inside them. So what's development then?
Right. Development is different. It's defined as the maturation of functions. This is the qualitative aspect. It's closely tied to the maturation and, crucially, the myelination of the nervous system.
Myelination. That's the fatty sheath around nerves, right? Makes signals travel faster.
Exactly. That increased speed and efficiency in the nervous system allows a child to acquire all sorts of skills needed for, optimal functioning. So while growth is about size increase, development is about capability increase. Things like learning to sit up, crawl, walk, talk, solve problems, interact socially. It's about increasing complexity and functionality.
Okay, I really like that distinction, quantity versus quality. It clears things up. It makes me think of maybe building a house, adding bricks, making rooms bigger, expanding the footprint. That's the growth part, right? Increasing size and mass. But the development part is like installing the plumbing, wiring the electricity, making sure the heating works, setting up the kitchen, basically making it functional so you can actually live in it.
That's a perfect analogy.
Yes.
The house gets bigger, that's growth. But if the systems inside don't mature and become functional, the plumbing, the electrics, it's not really a usable house. That's development. And your analogy also highlights their interconnectedness. They are distinct, as we said, but they're also closely related. So factors that affect one usually tend to impact the other as well. This synergy is absolutely critical to understand.
So they happen together, influencing each other. What does that actually look like in practice? How does this dynamic equilibrium between getting bigger and becoming more capable play out over time?
Well, it starts incredibly early, right from the embryonic stage. In the early embryo, you see this exponential increase in cell number, just massive multiplication. But these cells aren't just multiplying randomly, they're also differentiating. They're specializing to become all the different tissues and organs needed. Then, as you move into the latter half of pregnancy and through early childhood, there's a significant increase in cell size, not just number. You can actually measure this as an increase in the protein to DNA ratio within the cells. And this cell enlargement keeps happening up until about age 10 or so, contributing to that overall increase in body mass.
So first look, more cells, then the cells themselves get bigger.
Pretty much. And throughout life, the body's cells are in this constant state of dynamic equilibrium, Old cells die off, new cells replace them. The rate of this turnover varies a lot, though. Skin cells turn over really quickly, bone cells much more slowly.
Okay. So how does that link back to the synergy between growth and development?
Well, think about it. If there's a problem early on with cell multiplication, the growth aspects say not enough cells are produced for a particular organ. That's going to inherently disrupt the formation and structure of that organ, which then directly impacts its ability to mature and function properly later on. That's the development aspect.
Right. Like if the heart doesn't get enough cells early on, it might have structural problems that limit its function later.
Precisely. And it works the other way, too. If there's an issue with the nervous system's maturation, say, myelination is impaired, affecting development, it could hinder a child's ability to coordinate movements. That lack of coordinated movement might then indirectly affect muscle development or even bone density because the child isn't as physically active. That's development impacting growth.
Okay, I see. It's a constant feedback loop.
Exactly. They are truly inseparable aspects of a child's journey, constantly influencing each other. Understanding this deep connection is absolutely foundational if you want to grasp the complexities of child health and, well, what can go wrong?
That interconnectedness is key. Got it. Okay, let's zoom out a bit now and look at the bigger picture, the driving forces behind all this. You mentioned the journey starts even before birth with fetal growth. So what are the key factors shaping a baby's size and health while they're still in the womb? It sounds like a really complex interplay.
It really is a very intricate process where, as the source material puts it, the maternal placental fetal unit acts in harmony. Several big factors are involved. First, and this is a big one, is genetic potential. It turns out about 40% of the variation we see in birth weight is down to genetic factors. The rest is environment.
40%, that's quite substantial.
It is. It means parental traits usually get passed on. Tall parents tend to have taller children. But it's not just height. Things like head size, the structure of the chest, even how fatty tissue is distributed, these all have strong genetic links.
Okay, genetics is number one. What else?
Next is sex. On average, boys tend to be born a little bit taller and heavier than girls. It's a consistent, though usually small, difference at birth. Then you have the absolutely crucial role of fetal hormones. The fetus actually starts producing its own hormones quite early. Thyroxine and insulin are vital from early on for tissue growth, accretion, and differentiation. Glucocorticoids become particularly important later in gestation. They help mature critical organs like the liver, the lungs, the gut, getting the baby ready for life outside.
Makes sense. Preparing for the transition.
Exactly. But here's something interesting, maybe even counterintuitive. Growth hormone. You'd think it would be key, right?
Definitely.
Well, it's present in high levels in the fetus, but surprisingly, it's not actually known to directly influence fetal growth itself. Its major role comes later after birth.
That is surprising. So if growth hormone isn't the main driver in utero, what else is pushing that tissue growth and cell division?
That's where fetal growth factors come into play. These are substances, often proteins, that are actually synthesized locally, right within the fetal tissues themselves. They tend to act in what we call autocrine and paracrine ways, meaning they act on the cell that produced them or on nearby cells. Their main job seems to be stimulating cell division, really driving that increase in cell number. The most studied ones are probably the insulin-like growth factors, IGF-I and IGF-2. They are absolutely critical for orchestrating this complex cellular growth during fetal life.
Okay, so local growth factors are doing a lot of the work. What about the connection to the mother? The placenta must be vital.
Absolutely vital. There are key placental factors. There's a very direct correlation between the weight of the fetus and the weight of the placenta. A bigger, healthier placenta usually supports a bigger baby. Fetal growth really depends on the placenta's structural and functional integrity. It's the lifeline, delivering nutrients and oxygen, removing waste. As the pregnancy progresses, the placenta actually remodels itself. The surface area for exchange increases, the distance nutrients have to travel decreases. All these changes facilitate better nutrient transport to support the growing fetus. If that placental function is compromised for any reason, fetal growth will almost certainly be affected.
Right, the supply line makes sense.
Yeah.
And then, of course, there must be factors related to the mother herself.
Oh, definitely. A whole range of maternal factors. The mother's own health history is important, her own growth during childhood, her nutritional status, her body composition, both before she conceived and during the pregnancy itself. These all play a huge role. Then there are negative influences, things like being a very young mother or advanced maternal age, having pregnancies very close together, or the mother being anemic. These can all hinder fetal growth.
And lifestyle factors too, presumably.
Yes, definitely. Harmful substances are a major concern. If the mother uses tobacco smoked or chewed or abuses drugs or alcohol, these have direct detrimental effects on fetal growth. Obstetric complications during the pregnancy itself, like pregnancy-induced hypertension or preeclampsia or carrying multiple babies, can also restrict growth. And pre-existing chronic diseases in the mother, like kidney failure or heart failure, can impact the baby's growth. Finally, infections acquired during pregnancy, things like rubella, syphilis, CMV, toxoplasmosis, these can severely impact fetal development and growth.
Wow. Listing them all out like that really underscores the complexity and the huge importance of prenatal care, doesn't it? It's not just about managing the pregnancy itself, but supporting the mother's health before she even conceives. It really feels like interventions here, even early on, can literally shape a life trajectory.
That's exactly right. It highlights how interconnected everything is, from the cellular level within the fetus right up to the mother's health, her environment, and even broader public health measures. It all feeds into setting the stage for that individual's future.
Okay, so that's the complex picture before birth. Once the baby arrives, the context changes. A whole new set of factors, internal and external, start influencing growth. What are the key postnatal drivers we need to understand?
The interplay continues, yes, but with some shifts in emphasis. Genetic factors are still fundamental, of course. The child's genetic blueprint continues to guide their growth potential. And beyond just influencing height potential, this is where we see the impact of chromosomal disorders like Down syndrome or Turner syndrome, which often involve significant growth differences. Specific gene mutations can also cause conditions leading to either unusually short or tall stature, so genetics remains a cornerstone.
Right, the foundation is still there. What else comes into play after birth?
A really critical factor is the legacy of prenatal growth. If a baby experienced intrauterine growth restriction, IUGR, and was born with low birth weight, LBW, that's a major risk factor for problems after birth. Being born small significantly increases the odds by 3 to 5 times that a child will be underweight, stunted, or wasted during their first 5 years. It really shows how challenges starting in the womb can cast a long shadow.
That's a stark statistic. Underscores the importance of prenatal health again. What about the obvious one, nutrition?
Nutrition becomes absolutely paramount postnatally. In early infancy, the evidence strongly supports exclusive breastfeeding. It provides ideal nutrition and critically helps prevent infections, which can derail growth. However, sometimes practices like introducing animal milk supplements too early can actually backfire. They can increase the risk of infections, leading to underweight and stunting. It's a delicate balance.
And as they get older, introducing solids.
Yes, complementary feeding is another critical stage. Problems arise if solids are started too late, if the amounts are too small, or if the foods offered are low in energy density. Combine that with poor hygiene, and you see rates of underweight and stunting climb further. Beyond just calories, specific nutrient deficiencies are major culprits. Protein energy malnutrition is a big one, but also anemia due to iron deficiency or lack of zinc, iodine, or essential vitamins like A and D. These all directly retard growth.
And the opposite, too much food.
Yes, that's important too. Overnutrition, overeating, leading to obesity actually tends to accelerate somatic growth, like height gain, although obviously with its own set of health problems. So nutrition is a spectrum, and both ends have significant impacts on growth.
Okay, nutrition is key. What about hormones after birth? You mentioned growth hormone wasn't a big player in utero. Does that change?
It absolutely changes. Postnatal hormonal influence is critical. Normal growth simply cannot happen without the right hormonal environment. Growth hormone becomes essential. Its absence, or the absence of thyroid hormone, thyroxine, leads to dwarfism. This dramatically shows their importance after birth. And then later, during adolescence, the sex hormones, androgens, and estrogens take center stage. They drive that big pubertal growth spurt and are ultimately responsible for determining a person's final adult height.
And sex itself. Does the difference between boys and girls continue to influence growth patterns after birth?
Yes, it does. While boys are often slightly larger at birth, girls typically enter their pubertal growth spurt earlier. However, despite starting earlier, their overall mean height and weight at full maturity usually end up being less than boys. So sex continues to shape the timing and magnitude of growth throughout childhood and adolescence.
Interesting. Now, you mentioned infections briefly with breastfeeding. How big a factor are infections overall in postnatal growth, especially maybe in less resourced areas?
Infections are a huge factor, particularly in low-resource settings. They are often cited as one of the most common contributors to poor childhood growth in those contexts. Things like persistent or recurrent diarrhea or frequent respiratory tract infections are major culprits.
Why do they impact growth so much?
Well, fighting an infection takes energy and nutrients. Those resources get diverted away from growth processes towards the immune response. Plus, infections, especially gut infections like diarrhea, can severely impair nutrient absorption. It creates a really damaging cycle. There's data showing, for instance, that the risk of being stunted at age 2 increases with every episode of diarrhea a child experiences, and even with each day they have diarrhea. It's a direct, measurable impact.
That's sobering. What about other external factors? Chemicals, trauma.
Yes, those can play a role too. Certain chemical agents, like exposure to specific hormones, might initially speed up skeletal growth, but this can be deceptive and harmful. They can cause the growth plates at the ends of bones to fuse prematurely. So you might get a quick spurt, but it shuts down growth early, leading to a shorter final adult height. It's a critical warning about inappropriate hormone exposure, and trauma, specifically physical injury, can also impact growth. If a child suffers a fracture right near the end of a bone, particularly if it damages the growth plate, the epiphysis, it can directly hinder future skeletal growth in that specific limb.
It really paints a picture of vulnerability, doesn't it? So many biological factors at play. But you also hinted earlier that the environment, the social context is crucial too. These unseen architects. What are some of those powerful social determinants shaping growth?
You're absolutely right. It's not just biology in isolation. The social environment is incredibly powerful. Let's start with socioeconomic level. It's consistently shown that children from families with higher socioeconomic status tend to have better nutritional states and fewer infections, often due to better access to nutritious food and more hygienic living conditions. This sets them up for better growth.
And the flip side, poverty.
Exactly. Poverty is strongly associated with factors that impede growth hunger, undernutrition, increased exposure to infections. It creates significant barriers to achieving growth potential. On a larger scale, even a country's natural resources can play an indirect role. Abundant resources might fuel economic development, leading to improved nutrition and better living standards overall, which facilitates better growth outcomes on a population level. Climate is another, perhaps surprising factor. Studies have shown that the velocity, the speed of growth, can actually vary slightly with the seasons. This might be linked to seasonal variations in infection rates or even the impact of climate on agriculture, food availability, and people's ability to work.
Climate? Wow.
Wow.
That's not one I would have immediately thought of. What about emotional factors? You touched on this earlier with psychosocial dwarfism.
Yes, emotional factors are profoundly important. Research clearly shows that children growing up in emotionally deprived environments, say, from broken homes or certain institutional settings without adequate nurturing, often don't grow and develop optimally. The mechanism seems to be that chronic anxiety, insecurity, and a lack of love and emotional support can actually disrupt the brain's chemical regulation of growth hormone release. It's a direct physiological link between emotional state and growth.
That's incredible. The power of nurture literally affecting hormones.
It is, and it highlights how crucial a secure, loving environment is. Cultural factors also come into it. Different cultures have varying practices around child rearing, infant feeding, sanitation, even taboos against certain foods, all of which can influence nutritional status and health, and therefore growth. And finally, parental education, particularly the mother's level of education, is consistently linked to better child health outcomes. More educated parents are often better equipped to access information and adopt health-promoting behaviors, which directly and indirectly benefits their child's growth and development.
It really is a complex web. Biology, environment, social structures, culture, emotions, all woven together. Understanding these social determinants feels absolutely essential for any kind of holistic approach to child welfare, doesn't it? It certainly makes you think about what you see in your own community and all the hidden factors influencing children's lives. Okay, we've covered the forces that shape growth, both positive and negative. Now, let's focus on the consequences when growth is significantly impaired. You mentioned the impact of infections and low birth weight. When growth falters, especially early on, the consequences can be severe and long-lasting, right? What are we talking about in terms of health impacts, both immediate and down the road?
The consequences are profound, truly. On a global scale, maternal and child undernutrition is a massive issue. It's estimated to be the underlying cause of 3 to 5 million child deaths every single year. And beyond mortality, it accounts for about 35% of the total disease burden in children under 5. These are staggering numbers, representing immense suffering and lost potential.
3 to 5 million deaths. That's devastating.
It is, and the impact extends far beyond childhood illness or death. This brings us to a really critical concept that has revolutionized how we think about health across the entire lifespan. It's called the developmental origins of health and diseases hypothesis, often shortened to GHAI. You might also hear it referred to as the Barker hypothesis, after the researcher who pioneered much of this work.
GHAI, developmental origins of health and diseases. That sounds incredibly significant. Linking what happens early in life to adult health outcomes decades later. Tell us more about this. This feels like a core concept for really mastering this topic.
It absolutely is. It's a paradigm shift in many ways. The core idea of GHAI is that alterations or challenges experienced during critical periods of early development, especially fetal life and infancy, concerning nutrition and hormonal status can lead to permanent adaptations in the body's structure, physiology, and metabolism. These adaptations, sometimes called programming, essentially set the body on a particular trajectory. While they might be beneficial for survival in a challenging early environment, they can permanently alter how the body functions.
Okay, so the body adapts to early conditions, but those adaptations stick.
Exactly, they become embedded. And the key insight is that these permanent changes can then predispose that individual to developing various chronic diseases much later in adult life. We're talking about things like cardiovascular disease, metabolic diseases like type 2 diabetes, hypertension, high cholesterol, and certain endocrine disorders.
So, for example, the low birth weight you mentioned earlier.
Yeah.
How does that link to adult disease under this hypothesis?
Well, the evidence suggests that infants born with low birth weight, often resulting from poor nutrition or stress in the womb, have a significantly increased risk of developing diabetes, high blood pressure, and heart disease when they become adults. The theory is that the fetus, sensing a harsh or nutrient-poor environment, makes metabolic adjustments to conserve energy and survive. For instance, it might become more efficient at storing fat or develop insulin resistance. These adaptations help in the short term, in the womb. But later in life, especially if that individual lives in an environment with plentiful food, those same thrifty metabolic adaptations become detrimental, increasing the risk of obesity, diabetes, and related cardiovascular problems.
Wow. That completely reframes how we think about chronic disease prevention.
It absolutely does. It shifts the focus way upstream. It tells us that the foundations for lifelong health are laid down right from conception, through pregnancy, and in the first few years of life. It means that promoting optimal maternal health, ensuring good prenatal nutrition, supporting healthy infant growth, these aren't just about having a healthy baby now. They are critical public health strategies for potentially preventing major chronic diseases decades down the line.
That's a huge aha moment. Addressing health disparities in early childhood isn't just about fairness then. It's a long-term investment in preventing the biggest killers in adulthood.
Precisely. It underscores that nurturing in those foundational years leaves truly permanent imprints. Disease prevention starts long before adulthood. It starts at the very beginning. Understanding GHAI is absolutely essential for anyone wanting that elite professional-level grasp of health and development.
Okay, the GHAI concept is powerful. Linking early life to adult health really changes the perspective. Now let's shift back to the journey of growth itself. It can seem a bit chaotic watching a child grow, but is there an underlying order to it? You mentioned the research outlines some fundamental laws of growth. What are those?
Yes, despite individual variations, there's a remarkable predictability. The first law or principle is that growth and development are a continuous and orderly process. It doesn't happen randomly. It follows a pattern. There are distinct periods where the rate of growth changes significantly. For instance, the fetus grows incredibly fast, especially in the first half of gestation. Then the rate slows a bit leading up to birth. Immediately after birth, in early infancy, the velocity of growth is extremely high again, particularly in the first few months. You see dramatic changes in a newborn very quickly.
Right, they seem to change almost daily at the start.
They really do. Then, during mid-childhood, say from around age 2 or 3 up until puberty, the rate slows down. Growth is steadier, more consistent, but not as explosive as in infancy. Then comes puberty, which triggers a second major phase of accelerated growth, the adolescent growth spurt. After that spurt, growth slows down again, decelerates over a few years, and eventually ceases altogether when adult stature is reached. So if you look at the overall pattern, general body growth is rapid during fetal life, the first year or two after birth, and during puberty. In between, during mid-childhood, the pace is slower but steady.
Continuous and orderly, but with distinct phases of acceleration and deceleration. Got it. What about the direction of growth? Do different body parts grow in a specific sequence?
Yes, that's the next key principle. While the overall pattern is ordered, each individual's pattern is unique, but it follows predictable directional sequences. The main sequences are cephalocaudal, which means head to tail, and distal to proximal, meaning from the outer limbs inward.
Cephalocaudal, head to tail.
Right. Think about fetal development. The head and brain develop earlier and are proportionally much larger than the rest of the body initially. Development proceeds downwards. Control of the head comes before control of the trunk, which comes before control of the legs. A baby can lift its head before it can sit, and sit before it can walk.
Okay. And distal to proximal?
That refers to development progressing from the extremities towards the torso. For example, a baby gains control over its arms before it fine-tunes the movements of its fingers. Gross motor skills develop before fine motor skills.
Okay, so head downwards and outwards inwards, generally speaking.
Generally, yes, especially prominent in early development. Postnatally, the pattern shifts slightly. While the head grows very rapidly early on, its growth rate slows down considerably later, while the limbs continue to grow rapidly for much longer. This is why a baby's body proportions look quite different from a toddler's or an older child's. The body gradually catches up to the head, and the limbs elongate. These fundamental laws provide the predictable framework, the blueprint, for how growth unfolds.
That makes sense, the body fine-tuning its proportions. Now, it's not just the body as a whole. You mentioned different tissues and organs grow at their own specific paces. What does this differential tissue growth look like? Can you give some examples?
Absolutely. This is another layer of complexity and coordination. A prime example is brain growth. The brain undergoes phenomenal growth during the later months of fetal life and the first couple of years after birth. Consider this. At birth, a baby's head circumference is already about 65–70% of its final adult size. By age 2, it reaches about 90%.
90% by age 2. That's incredible.
It really is. It highlights why that period, late pregnancy in the first 2 years, is so incredibly critical for brain development. Any disruption during that time can have profound, long-lasting consequences.
Okay, so the brain grows super fast early on. What about other tissues?
They follow different timelines. Gonal growth, the development of the ovaries and testes, is pretty much dormant throughout most of childhood. They don't really start growing significantly until puberty hits. Then you have lymphoid tissue. This includes things like the tonsils, adenoids, thymus, and lymph nodes, parts of the immune system. This tissue actually shows its most rapid growth spurt during mid-childhood, maybe from around age 4 to 8 or 10. During this time, the total mass of lymphoid tissue can actually be larger than it will be in adulthood. This is why it's perfectly normal for young children in this age range to have seemingly large tonsils or easily palpable lymph nodes. It's just a sign of this normal accelerated lymphoid growth phase.
That's useful to know. Parents might worry otherwise.
Exactly. It's physiological for that age. Finally, let's look at body fat and muscle mass. The body is broadly composed of fat and fat-free components. The fat-free part, or lean body mass, includes muscle, organs, and the skeleton. Growth in lean body mass is mostly due to an increase in muscle mass. Generally, taller children have greater lean body mass, and after puberty, boys typically develop significantly more lean body mass than girls. Body fat, on the other hand, is our energy storehouse, mostly subcutaneous under the skin. Girls tend to have a higher percentage of body fat than boys throughout life, and its distribution also differs, especially after puberty, contributing to differences in body shape.
So it's like different instruments in an orchestra reaching their peak volume at different times, all contributing to the final composition.
That's a great way to put it. It's a highly synchronized yet differential growth of all the individual components that shapes the child into their adult form.
So intricate. Okay, let's focus now on the body's framework, the skeleton, and also those first teeth. What are the key milestones in somatic growth, specifically skeletal and dental development?
Right. The skeletal growth is fundamental. It's a continuous process all through childhood and adolescence. It proceeds fairly steadily, then accelerates dramatically during the pubertal growth spurt, and then slows down until it finally stops. We consider the skeleton fully mature when the growth plates, or epiphyses, at the ends of the long bones fuse completely to the main shaft, the diaphysis.
And when does that fusion typically happen?
It varies slightly, but generally around 18 years of age in girls and a bit later, maybe 20 to 22 years in boys. And interestingly, the degree of skeletal maturation, how old the bones look, closely correlates with the degree of sexual maturation. So a child hitting puberty early will usually show more advanced skeletal maturation as well.
How do you assess that skeletal maturation?
Primarily by looking at x-rays, usually of the hand and wrist. We look at the appearance and fusion of those epiphyseal centers. This allows us to estimate the bone age. Bone age is a crucial measure. It tells us how far along the skeleton is in its maturation process and gives an idea of the remaining growth potential. It can be quite different from a child's actual chronological age, especially if there's a growth disorder.
Bone age, okay. Important for diagnosing issues. What about teeth?
The eruption of teeth follows its own predictable schedule, too. First come the primary teeth, the baby teeth. There's a typical order and timing for when they emerge, usually starting in the first year of life. Generally, teeth in the upper jaw come through slightly earlier than the corresponding ones in the lower jaw, with a couple of exceptions like the lower front teeth. After all the primary teeth are in, there's a pause, and then the permanent teeth start to erupt, usually beginning around age 6 with the first molars. They gradually replace the primary teeth over several years. Tracking these skeletal and dental milestones gives us really valuable markers of a child's overall physical maturation, helping to assess if development is proceeding typically.
Fantastic. It gives us a clear picture of the underlying processes and patterns. Now let's transition to how we actually measure and monitor all this. How do professionals precisely assess a child's physical growth? It's got to be more involved than just standing them against a wall chart at home.
Oh, much more involved, yes. Accuracy is key. The science of it is called anthropometry, and it relies on standardized tools and very specific techniques. Let's start with weight. Ideally, the child should be weighed nude or wearing only minimal light clothing. You need a reliable scale lever, or electronic types are preferred, as spring balances can be less accurate. The child needs to be placed right in the middle of the weighing pan. And critically, the scale must be checked for zero error before each measurement. If you're tracking weight over time, you should ideally use the same scale each time for consistency.
Okay, consistency and accuracy. What about really small babies who can't stand?
For them, there's a technique called tiered weighing. The mother or caregiver stands on the scale first, and the scale is tiered or zeroed out with them on it. Then the baby is carefully handed to the person on the scale. The scale reading will then show only the baby's weight. It's quite clever and practical.
That is clever. Okay, that's weight. What about measuring how long they are, especially infants who can't stand?
For children under 2 years old, we measure their length while they're lying down, supine. This requires a special rigid measuring board, often called an infantometer. It's usually a two-person job for accuracy. One person holds the baby's head firmly but gently against the fixed headboard, making sure the head is looking straight up. The second person carefully straightens the baby's legs and feet, ensuring the knees aren't bent, and brings a movable footboard up to touch the baby's heels firmly, with the feet at right angles to the legs. The measurement is then read from the scale on the board.
Sounds like it requires some coordination, especially with a wiggly baby.
It definitely does. Precision is vital. You can't just use a tape measure on a mattress. It won't be accurate enough.
Right. So once they're over 2 and can stand, how do you measure standing height accurately?
For children over 2, we measure standing height using a stadiometer, which is basically a vertical ruler with a sliding headpiece, often mounted on a wall. Again, preparation is important. Shoes off, and any bulky hair ties or ornaments removed. The child stands straight and tall with their heels slightly apart but flat on the floor. Their heels, buttocks, shoulder blades, and the back of their head should all be touching the vertical surface of the stadiometer. Their head needs to be positioned correctly, looking straight ahead, usually aligned with what's called the Frankfurt plane, being horizontal. Then the headpiece is brought down firmly onto the crown of the head, compressing the hair slightly, and the measurement is read.
Okay, specific posture is key there too. What other measurements are commonly taken?
Beyond height and weight, several circumferences are important. Head circumference, HC, is measured using a non-stretchable tape measure placed around the largest part of the head, from the forehead just above the eyebrows to the most prominent part at the back of the head, the occiput. Chest circumference is measured at the level of the nipples, usually midway between breathing in and breathing out. And mid-upper arm circumference, MUAC, is particularly useful for assessing nutritional status, especially in resource-limited settings. You find the midpoint between the bony tip of the shoulder, acromion, and the point of the elbow, olecranon, on the upper arm. Then you wrap the tape measure around the arm at that midpoint. The tape should be snug, but not tight enough to compress the skin.
MUAC, okay, I've heard that's a key indicator for malnutrition.
It is, yes, a very valuable and relatively simple measurement. Finally, we often calculate body mass index, BMI. That's the weight in kilograms divided by the height in meters squared. For children, BMI is interpreted differently than for adults, using age and sex-specific charts, and it's primarily used as a screening tool for overweight and obesity.
So a whole toolkit of precise measurements. Once you have these numbers, how do you interpret them? How do you know what's normal? Or if a child is genuinely on track? It can't just be one single number defining normal, can it?
No, absolutely not. Normal and growth assessment is really about a range. Generally, we define the normal range based on data from large groups of healthy children. Typically, normal growth is considered to fall within a specific range on growth charts, usually defined by percentile curves. The standard definition of the normal range is often taken as being between the 3rd and the 97th percentiles for a given age and sex.
Percentiles. So comparing the child to where they fall within that healthy reference population.
Exactly, and what's often more important than a single measurement is the pattern of growth over time. Most healthy children will tend to follow along a particular percentile curve as they grow. Their measurements might consistently track along the 50th percentile or the 25th or the 75th. A significant deviation from their established curve, say suddenly dropping from the 75th percentile down to the 25th, is a red flag. It could signal a recent illness or developing problems with nutrition, either under or over nutrition.
So the trajectory matters as much as the single point.
Very much so. Also, for babies born prematurely, we need to adjust their age. We subtract the number of weeks they were born early from their chronological age when plotting them on the charts, especially in the first couple of years. This corrected age gives a fairer comparison.
That makes sense. Are there general milestones or rules of thumb for weight and height gain that professionals keep in mind?
Yes, there are some useful benchmarks, though individual variation is always expected. For weight, the average birth weight is around 3 kilograms, maybe a bit more. Newborns lose a bit initially, maybe up to 10%, but should regain it by day 10 or so. Then they gain rapidly, often doubling their birth weight by about 5 months and tripling it by their first birthday, around 9 to 10 kilograms. Weight typically quadruples by age 2. After that, the gain slows to about 2-3 kilograms per year until puberty kicks in.
Okay, doubling by 5 months, tripling by a year. That's rapid. What about length or height?
For length height, the average at birth is around 50 centimeters. By 1 year, it's typically around 75 centimeters, and by 2 years, about 90 centimeters. A common milestone used, especially for Indian children according to some sources, is reaching 100 centimeters around age 4. After age 4, children usually gain about 5 to 6 centimeters per year until the pubertal spurt.
And head circumference, you said that reflects brain growth.
Yes, head circumference, HC, is crucial in infancy. It starts around 34-35 centimeters at birth and grows very quickly in the first year, reaching about 46-47 centimeters by 12 months. By age 2, it's around 48 centimeters. That rapid early growth mirrors the explosive brain development happening inside. Chest circumference starts a bit smaller than head circumference, but usually catches up and becomes equal by about 1 year of age, and then typically exceeds HC after that.
That gives a good sense of the typical progression. You mentioned percentiles, but I've also heard about z-scores being used. What are those?
Right. Z-scores, or standard deviation scores, are another way to express how far a child's measurement is from the average or median value for their age and sex. A z-score tells you exactly how many standard deviations a measurement is above or below the median. A z-score of 0 is exactly average. A z-score of +1 means 1 standard deviation above average. A -2 means 2 standard deviations below average, and so on.
Why use z-scores instead of just percentiles?
Z-scores are often preferred in clinical and research settings because they are more statistically precise, especially at the extremes of the distribution, very high or very low values. They allow for more accurate tracking of changes over time and for comparing measurements across different indicators, like comparing a weight z-score to a height z-score. They're particularly useful for identifying children with moderate or severe growth problems.
Okay, z-scores offer more precision, especially at the extremes. Now, plotting these measurements, whether as percentiles or z-scores, on growth charts seems like the standard way to visualize everything. Tell us more about these charts.
Absolutely. Growth charts are the essential tool. They allow you to visually track a child's growth over time against a reference population of healthy children. Their primary purpose is to help diagnose deviations from the normal growth pattern. The curves you see on the chart represent percentiles or z-score lines derived from that reference population data. As we said, if a child's height plots on the 25th percentile line, it means 25% of healthy children of that age and sex are shorter, and 75% are taller. The area between the 3rd and 97th percentiles, or between -2 and +2 z-scores, is generally considered the normal range.
Have these charts always been the same, or have they evolved?
They've definitely evolved. Older charts, like the NCHS charts from 1977 or the CDC charts from 2000, were often based primarily on data from children in the U.S., many of whom were formula-fed. A major development came in 2006 with the WHO Multicentre Growth Reference Study, MGRS. This was a landmark study.
What made the WHO MGRS charts so different?
Several things. First, they were internationally based, collecting data from children in 6 diverse countries across different continents: Brazil, Ghana, India, Norway, Oman, and the US. Second, they were designed to be prescriptive rather than just descriptive. They aimed to show how children should grow under optimal conditions, not just how they were growing in a specific population at a specific time. Critically, the WHO study used breastfed infants as the biological norm for infant feeding, reflecting best practices.
That seems like a really important shift, focusing on optimal growth and breastfeeding.
It was, and the study found that child populations actually grow remarkably similarly across the world's major regions when their basic health and nutritional needs are met. This supported the idea of a single international standard for children up to age 5. The WHO charts also included new indicators, like standards for skin fold thickness to help assess obesity, and importantly, because they followed children over time, longitudinal data, they could develop standards for growth velocity, which helps identify problems like under- or overnutrition earlier based on the rate of growth.
So the WHO 2006 charts are now the standard for younger children.
Yes, they are widely recommended and used globally for children up to 5 years old. For older children and adolescents from 5 to 18 or 19 years, different reference charts are often used, sometimes based on more recent national data, like the updated CDC charts or charts developed specifically for certain populations, like the Indian Academy of Paediatrics, IAP charts, based on Indian children.
Okay, so we have these powerful charts.
Yeah.
How often should children actually be monitored? What are the practical guidelines for growth monitoring?
Growth monitoring should be integrated into routine child health care. Guidelines, like those from the IAP, often suggest measurements at specific intervals, particularly frequent in the first year or two, aligning with vaccination visits. For instance, measurements at birth, then around 1.5, 3.5, 6, 9, and 15 months. After that, perhaps every 6 months up to age 8, and then annually through adolescence, ages 9, 19. During adolescence, it's also important to monitor sexual maturity rating, SMR, alongside height and weight, as puberty profoundly impacts growth. The key is regular, consistent monitoring using accurate techniques and appropriate charts.
And how are the measurements interpreted using the charts and z-scores, especially for classifying problems?
There are specific cutoffs, usually based on z-scores, used for classification, particularly for children under 5 using the WHO standards. For example, a length height for age z-score below NACA2 is classified as stunted. A weight for age z-score below MACA2 is underweight. For assessing thinness or overweight, we look at weight for length height, or BMI for age. A z-score below MACA2 in these indicates wasting thinness, while a score above +1 suggests risk of overweight, above +2 is overweight, and above +3 is obese.
So clear definitions based on the z-scores.
Yes. And it's important to remember, as we discussed, that these conditions can coexist. A child can be stunted, too short for their age due to chronic undernutrition, but also be overweight or obese, too heavy for their height due to current excess calorie intake. This reflects the complexity of malnutrition.
That's a crucial point. Okay, we have the charts, the techniques, the interpretation. In today's world, I assume technology plays a role too. Are there software tools or apps that help with all this?
Definitely. Technology makes analysis much easier and more accessible. The WHO itself provides free downloadable software called WHO Anthro. It has different modules. You can use it as an anthropometric calculator for a single measurement, track an individual child's growth over time, or even analyze data from nutritional surveys. It can generate z-scores, percentiles, and plot growth charts.
It sounds very useful for professionals. What about mobile apps?
Yes, there are numerous mobile apps available now, both free and paid. They offer instant analysis right on your phone or tablet. Most use either the CDC or WHO growth charts, and some let you choose. They calculate percentiles and z-scores quickly based on the measurements you enter. Some apps also include other useful pediatric calculators. They can be very handy tools for clinicians, researchers, and even informed parents, though users should always ensure the app is using appropriate and up-to-date reference standards.
It's clear that measuring and monitoring growth is a precise science with powerful tools available. We've established what typical growth looks like and how it's assessed. Now let's turn to what happens when growth doesn't follow the expected path. This brings us to growth disorders and abnormalities. Let's start with a common concern: short stature. How is it formally defined, and what are the very first steps in figuring out why a child might be significantly shorter than their peers?
Right. Short stature is a frequent reason for parents to seek medical advice. Clinically, it's generally defined as having a height that falls below the third percentile for the child's age and sex on standard growth charts. Or, using z-scores, it's a height that is more than 2 standard deviations below the median height, manic 2 FD. Now, statistically, this means about 3% of all children will fall into this category. Not all of them will have an underlying medical problem, but it warrants investigation. If a child's height is even further below the norm, say below -3 SD, it's much more likely that there's a pathological or disease-related cause.
Okay, below the third percentile, or -2 SD, is the trigger for assessment. What are the typical causes doctors consider first?
The causes are really varied. On a global level, especially in many developing countries, undernutrition and chronic systemic illnesses are among the most common culprits. Think about chronic infections, kidney disease, severe asthma, inflammatory bowel disease, anything that puts a long-term strain on the body or affects nutrient absorption. After those, endocrine problems like growth hormone deficiency, GHD, or hypothyroidism, underactive thyroid, are important considerations. There are also genetic syndromes, skeletal problems, and, as we discussed, psychosocial factors.
So a wide range of possibilities. What are the key steps in the assessment process? How do you start sorting through these causes?
It's a systematic approach. The absolute first step is accurate height measurement. You need reliable measurements taken correctly using an infantometer for under 2s or a stadiometer for older children, as we discussed. Inaccurate measurements can lead to unnecessary worry or misdiagnoses.
Measurement accuracy first. Makes sense. What's next?
Next, and this is critically important, is assessing height velocity. This isn't just about how tall the child is now, but how fast they have been growing over a period of time, usually expressed as centimeters per year. We compare the child's growth rate to the normal velocity expected for their age. For example, infants grow incredibly fast, maybe 25 centimeters in the first year. Then it slows in childhood, maybe 4 to 6 milliliter before puberty, then speeds up again during the pubertal spurt, maybe 10-12 centimeter peak.
Why is velocity so important?
Because a significantly low height velocity for age is often the earliest and most sensitive indicator that something is wrong. A child's height might still be within the normal range on the chart, but if their growth rate has slowed down dramatically, it's a major red flag suggesting a potential pathological cause that needs investigation. It helps predict future height and identify problems early.
Okay, velocity is key. What else?
Then, you compare the child's current height with population norms by plotting it accurately on the appropriate growth chart and determining their percentile or z-score. You also compare their height potential with their genetic potential by calculating the mid-parental height, MPH. This uses the parent's heights to estimate a target height range for the child.
How do you calculate that mid-parental height?
There are simple formulas. For boys, it's roughly mother's height in centimeter plus father's height in centimeters plus 13 centimeters divided by 2. For girls, it's choral. Mother's height in centimeter plus father's height in centimeter 13 centimeter divided by 2. It gives you an approximate target height, helping you see if the child's current trajectory is heading towards their genetic potential or falling short.
Okay, comparing to norms and genetic potential. What else?
Assessing body proportions is crucial. Is the short stature proportionate? Trunk and limbs are equally short, or disproportionate, limbs are unusually short or long relative to the trunk. Measuring the ratio of the upper body segment, sitting height, to the lower body segment, leg length, often called the USLS ratio, and comparing arm span to height helps differentiate here. Disproportionate short stature often points towards skeletal dysplasias, bone growth disorders, or conditions like rickets. Finally, in older children approaching or going through puberty, assessing their sexual maturity rating, SMR, using Tanner staging is vital. The timing of puberty and the associated growth spurt is tightly linked to final height. Early puberty can lead to an early spurt but premature fusion of growth plates and ultimately short stature. Delayed puberty causes delayed growth and can also result in being short during adolescence, though final height might be normal.
Wow, quite a comprehensive initial assessment. Accurate measurement, velocity, comparison to norms in genetics, proportions, and puberty status. That gives a lot of information to start narrowing things down. So with all that initial assessment data and recognizing the huge range of potential causes, how do doctors actually pinpoint the specific reason for a child's short stature? What's the diagnostic workup involved?
It's really about integrating all the clues. The detailed history is incredibly important. Are there clues like low birth weight, suggesting SGA, symptoms like excessive urination pointing to kidney issues, chronic diarrhea suggesting malabsorption, headaches perhaps hinting at a brain lesion affecting pituitary hormones? Was there neonatal hypoglycemia, which can occur in hypopituitarism? Is the diet clearly inadequate? Is there a family history of delayed puberty? What's the psychosocial environment like? All these historical details are critical pieces of the puzzle.
So history first, then the physical exam.
Yes, the physical examination provides more clues. Does the child have disproportionate limbs suggesting a skeletal dysplasia? Are there unusual facial features, dysmorphism, hinting at a genetic syndrome? Signs like pallor, anemia, high blood pressure, kidney disease, a goiter, thyroid issue, or specific body fat distribution, Cushing's syndrome. These findings help direct the investigation.
Okay, history and exam narrow the possibilities. What about tests? You mentioned bone age earlier.
Bone age assessment is essential for virtually all children being evaluated for short stature. As we discussed, it's usually done via an X-ray of the left hand and wrist. It tells us about skeletal maturity and remaining growth potential. How the bone age compares to the child's chronological age and their height age, the age for which their current height would be average, provides crucial diagnostic information.
How so? What do the different patterns suggest?
Well, if the bone age is significantly delayed compared to the chronological age, that's seen in most causes of pathological short stature, like GHD, hyperthyroidism, chronic illness, or constitutional delay. If the bone age is roughly equal to the chronological age in a short child, it might suggest familial short stature, where they are growing appropriately for their genetics but are simply destined to be short. If the bone age is advanced compared to the chronological age, that could indicate precocious early puberty, where early exposure to sex hormones is causing bones to mature too quickly. And if the bone age is delayed but roughly matches the child's height age, that's typical of constitutional growth delay or short stature due to undernutrition or systemic illness. If the bone age is even more delayed than the height age, especially if diagnosis is late, that can be a strong pointer towards GHD or hypothyroidism.
That bone age interpretation seems really powerful diagnostically. What about blood tests and other investigations?
Laboratory investigations are usually done in a tiered approach. Level 1 tests are essential screening tests for common underlying problems. This includes a complete blood count, looking for anemia, infection, ESR, inflammation marker, urinalysis, checking kidney function, potential infections, stool examination for parasites, malabsorption, basic metabolic panel, checking kidney function, electrolytes, calcium, phosphate, alkaline phosphatase, which is important for bone, fasting blood sugar, and liver function tests.
Okay, screening for the common stuff first. What if those are all normal?
If those initial tests are normal, and especially if the bone age is delayed, you move to level 2. This typically involves checking thyroid function, serum T4 and TSH. In girls with unexplained short stature, a karyotype, chromosome analysis, is usually done to rule out Turner syndrome, which is a relatively common cause.
And if those are normal too?
If level 2 tests are normal, and significant short stature or poor growth velocity persists, then you consider level 3 investigations. This is where you start testing for less common but important causes, like growth hormone deficiency or celiac disease, a type of malabsorption. Testing for GHD usually involves provocative growth hormone testing, stimulating GH release and measuring levels, and checking related factors like IGF-1 and IGF-BP3. Celiac testing involves specific antibody blood tests. Depending on the results, particularly if GHD is suspected, an MRI of the brain might be done to look at the pituitary gland.
That tiered approach makes sense, starting broad and getting more specific based on the findings. Let's dive a bit deeper into some of those specific types or causes of short stature that you mentioned. Can you elaborate on familial short stature and constitutional growth delay? They sound like common non-pathological variants.
Yes, they are important to distinguish. With familial short stature, you have a child who is short. Their height is below the 3rd percentile, but they are actually growing appropriately according to their own family's genetic pattern. Their parents are likely short too. These children might show some catch-down growth in the first couple of years, settling onto a lower percentile curve that aligns with their genetic target. But after age 2, their growth velocity is normal. They just track along that lower curve. Their body proportions are normal. Their bone age matches their chronological age. Puberty occurs at a normal time, and their final adult height ends up being short, but appropriate for their family background.
Okay, so basically healthy, just genetically short, following the family pattern. How does constitutional growth delay differ?
Constitutional growth delay, sometimes called late bloomer, presents differently. These children typically have a normal length and weight at birth. They grow normally for the first 6 to 12 months, but then their growth rate decelerates, causing them to fall below the third percentile on the charts, usually between age 1 and 3. After this deceleration, they usually resume a normal height velocity, but they remain on that lower percentile track during childhood. The key distinguishing features are delayed puberty and a delayed adolescent growth spurt compared to their peers. Because the spurt is delayed but often normal in magnitude, their final adult height usually ends up being within the normal range, often similar to their parents. Crucially, their bone age is delayed compared to their chronological age, but it typically corresponds well to their height age. A family history of similar delayed puberty, late blooming, in parents or relatives is very common.
So the key differences are really velocity patterns, bone age, timing of puberty, and final height outcome relative to genetics.
Exactly. Familial short stature has normal velocity after infancy, normal bone age, normal puberty timing, and short final height consistent with genetics. Constitutional delay has a period of deceleration, then normal velocity, delayed bone age, delayed puberty, but typically a normal final height. Distinguishing between them relies on careful history, serial measurements, and bone age assessment.
That's very clear. What about undernutrition as a cause? You said it's very common.
Yes, particularly in resource-limited settings, undernutrition remains the most common cause of poor growth and short stature. The diagnosis is usually made through a detailed dietary history revealing inadequate intake of calories or protein, combined with other clinical signs of malnutrition like low weight for height or a low mid-upper arm circumference, MUAC. Addressing the nutritional deficiencies usually leads to catch-up growth.
And skeletal dysplasias. Those sound more severe.
They generally are. Skeletal dysplasias are a large group of genetic disorders affecting cartilage and bone formation. They often result in disproportionate short stature, meaning the limbs might be significantly shorter than the trunk, or vice versa, and often quite severe short stature overall. Diagnosis involves careful assessment of body proportions, examining limbs and skull shape, family history, and usually requires a skeletal survey, a series of x-rays covering the whole skeleton, to identify characteristic bone abnormalities.
What about specific genetic syndromes?
Many genetic syndromes are associated with short stature. Turner syndrome, affecting girls, missing or altered X chromosome, is a relatively common one, occurring in about 1 in 2,000 live female births. Short stature is a key feature, though other classic signs might be subtle or absent. Other examples include Down syndrome, Prader-Willi syndrome, Russell-Silver syndrome, each with its own constellation of features alongside the growth impairment. Karyotyping and specific genetic testing might be needed for diagnosis.
You also mentioned psychosocial dwarfism again. That connection between emotional state and growth hormones is fascinating.
It really is. This condition, also called emotional deprivation dwarfism, is seen in children experiencing severe emotional neglect or abuse. They develop a functional state that mimics hypopituitarism. Their bodies don't secrete growth hormone properly in response to stimuli, and levels of IGF-1 are low. But the remarkable thing is, giving these children growth hormone treatment doesn't help. The underlying issue isn't a primary pituitary problem. It's the severe emotional distress suppressing the system. The treatment is removing the child from the damaging environment and providing a nurturing, supportive, loving atmosphere. When that happens, they often show dramatic catch-up growth. It powerfully illustrates the profound mind-body connection in growth.
A stark reminder of the importance of nurture. Lastly, you mentioned children born small for gestational age, SGA. What's the long-term picture for them?
SGA refers to babies born with a weight or length below the 10th percentile for their gestational age. The majority of these infants, maybe 70–80%, exhibit catch-up growth in the first 2 years of life and reach a height within the normal range. However, a significant minority, perhaps 20–30%, fail to show adequate catch-up growth and remain persistently short throughout childhood. The exact reasons aren't always clear, but subtle defects in the growth hormone and insulin-like growth factor, GHIGF axis, are thought to play a role in some cases.
Okay, that covers a lot of the specific causes.
Yeah.
So once a diagnosis is made, what does the management of a short stature look like? What can actually be done?
Management really depends on the underlying cause, but there are some general principles. First, parental counseling and support are crucial. It's important to help parents understand the diagnosis, manage expectations, focus on the child's positive attributes, and avoid putting undue emphasis solely on stature, which can affect the child's self-esteem. Second, ensuring a balanced diet with adequate macro and micronutrients is fundamental for all children, regardless of the cause. For physiological variants like familial short stature or constitutional delay, the main approach is reassurance and regular monitoring, pre-G annual height checks, to ensure the pattern remains consistent with the diagnosis. If the short stature is due to undernutrition or an underlying treatable condition like celiac disease, hypothyroidism, renal tubular acidosis, then treating the primary condition is the main goal. Correcting the diet or managing the underlying disease usually leads to satisfactory catch-up growth.
What about specific therapies like growth hormone?
Specific therapies are reserved for specific diagnoses. For hypothyroidism, thyroid hormone replacement, levothyroxine, is simple and effective. For children with confirmed growth hormone deficiency, GHD, treatment involves daily subcutaneous under-the-skin injections of recombinant human growth hormone. This therapy can significantly improve growth velocity and final adult height in children with GHD. Growth hormone therapy has also been approved for a few other specific conditions associated with short stature, such as Turner syndrome, children born SGA who fail to catch up, and children with chronic renal failure before transplant. However, it's important to note that in these non-GHD conditions, the doses required are often higher, and the improvement in final height tends to be smaller and more variable than in classic GHD. For some skeletal dysplasia causing severe limb shortening, complex surgical procedures for limb lengthening might be considered in specialized centers, but these are major interventions with potential complications. In all cases requiring treatment, regular and accurate monitoring of height in response to therapy is absolutely mandatory.
It's good to know there are effective treatments for specific causes. Now, shifting slightly, you mentioned another broad term earlier, failure to thrive, FTT. How does this relate to or differ from short stature? What does FTT actually mean?
That's a good distinction to make. Failure to thrive, or FTT, isn't a specific diagnosis itself, but rather a descriptive term. It's generally used for infants and young children, typically up to age 5, whose physical growth is significantly less than that of their peers. It usually implies inadequate weight gain. Common criteria include weight falling below the 3rd or 5th percentile for age, a weight trajectory that crosses 2 major percentile lines downward on the growth chart, or simply a documented failure to gain weight adequately over time. While short stature focuses specifically on height, FTT primarily focuses on poor weight gain, though height can also be affected, especially if the problem is chronic.
So FTT is more about inadequate weight gain in young children. What causes it? Is it similar to short stature causes?
There's overlap, but the emphasis is slightly different. FTT is traditionally classified based on etiology into organic and non-organic causes. Organic FTT means there's an identifiable underlying medical condition interfering with nutrient intake, absorption, metabolism, or increasing energy needs. This could be anything from gastroesophageal reflux, malabsorption syndromes like celiac disease, chronic infections, congenital heart disease, neurological problems like cerebral palsy affecting feeding, kidney disease, endocrine disorders, or even rare genetic or metabolic conditions. Non-organic FTT, sometimes called psychosocial FTT, is much more common, accounting for up to 80% of cases in some studies. Here, the primary issue is inadequate caloric intake due to environmental, social, or behavioral factors rather than an underlying disease.
What kind of factors lead to non-organic FTT?
It can be complex. Poverty leading to food insecurity is a major factor. Lack of knowledge about appropriate feeding practices, for example, improper formula mixing, delayed introduction of solids, difficulties with breastfeeding, dysfunctional parent-child interactions affecting feeding dynamics, maternal depression or substance abuse. Sometimes neglect or stressful home environments play a role. It's often multifactorial. And importantly, organic and non-organic factors can coexist. For example, a child with cerebral palsy, organic, might also experience feeding difficulties exacerbated by caregiver stress, non-organic.
So up to 80% non-organic. That highlights the huge impact of caregiving and environment on basic weight gain. How is FTT assessed and managed?
Assessment starts with confirming poor growth using serial measurements plotted on growth charts. Then, a very detailed history is taken, focusing heavily on feeding practices, what, how much, how often, feeding environment, difficulties, psychosocial factors, and any symptoms suggesting underlying illness. A thorough physical examination looks for signs of malnutrition or underlying disease. Observing a feed and the parent-child interaction can be very revealing. Extensive laboratory testing usually isn't necessary unless the history or exam strongly points towards a specific organic cause. Basic screening tests like a complete blood count, urinalysis, and maybe electrolytes might be done initially if indicated. A key diagnostic and management step, especially when non-organic FTT is suspected, is nutritional intervention. Providing adequate calories in a structured, supportive feeding environment and observing the child's weight gain response is crucial. If the child gains weight well with adequate feeding, catch-up growth, it strongly supports a non-organic cause and confirms that the primary issue was insufficient intake. Management then focuses on addressing the feeding problems and any underlying psychosocial issues. If there's no catch-up growth despite adequate intake, further investigation for organic causes is warranted.
That makes sense. Focusing on intake first for FTT seems logical, given how common non-organic causes are. Okay, our discussion on growth wouldn't be complete without talking about the head itself, the command center for so much development. What can abnormalities of head size and shape tell us?
Head growth is incredibly important because it closely reflects underlying brain growth, especially in the first few years of life. So significant deviations in head size or shape are always a concern and require careful evaluation.
Let's start with a head that's unusually large. What's that called and what might cause it?
An abnormally large head is called macrocephaly. It's formally defined as an occipitofrontal circumference, OFC, that largest measurement around the head that is more than 2 standard deviations above the mean for the child's age and sex. There are several potential reasons for a large head. One category is megalencephaly, which means the brain tissue itself is actually enlarged. This can sometimes be familial, running in families, often benign, or associated with various genetic syndromes or metabolic disorders. In benign familial megalencephaly, the child might have a large head, but be otherwise completely normal neurologically and developmentally. Another major cause is an increase in cerebrospinal fluid, CSF, within the skull. This is typically hydrocephalus, which can result from increased CSF production, decreased absorption, or an obstruction blocking its normal flow. Sometimes there can be a benign enlargement of the fluid-filled spaces around the brain that resolves on its own. Other less common causes of macrocephaly include enlargement of blood vessels, like an arteriovenous malformation, bleeding inside the skull, intracranial hemorrhage, thickening or expansion of the skull bones themselves due to certain bone diseases, or even space-occupying lesions like cysts, abscesses, or tumors.
So a large head could mean a large brain, too much fluid, or other issues. How is it evaluated?
Evaluation is definitely indicated if the head circumference is very large, for example 3SD above the mean, or if it's enlarging progressively and rapidly, crossing percentile lines upwards. Measuring the parent's head circumferences is important, as familial large heads are common. Usually, cranial imaging, often starting with an ultrasound through the fontanelle in infants, or later CT or MRI scans, is required to determine the underlying cause. Treatment depends entirely on that cause. Benign conditions might just need monitoring, while hydrocephalus often requires neurosurgical intervention, typically placing a shunt to drain the excess fluid.
Okay, that's macrocephaly. What about the opposite, an unusually small head?
An abnormally small head is called microcephaly. The definition here is usually stricter. An occipitofrontal circumference more than 3 standard deviations below the mean for age and sex. Using a nidus 2SD cutoff might include some constitutionally small but otherwise healthy children. Microcephaly generally implies that the underlying brain is also abnormally small, microcephaly.
Why would the brain and head be too small? What causes microcephaly?
The causes are very diverse and can occur at different stages. Primary microcephaly results from problems during early brain development, where not enough neurons are generated or migrate correctly. This is often genetic. Secondary microcephaly occurs when a previously normal-sized brain suffers an injury or insult that causes it to stop growing properly or even shrink. The list of potential causes is long. It includes genetic factors, isolated or part of syndromes like trisomy 21, 18, or 13, structural brain malformations, certain metabolic disorders, significant maternal conditions during pregnancy, like infections, CMV, Zika, rubella, or exposure to toxins like alcohol or certain drugs, severe malnutrition or major insults around the time of birth, like severe lack of oxygen, hypoxic ischemic encephalopathy, or persistent low blood sugar. Endocrine problems like severe hypothyroidism can also play a role.
So many potential insults or genetic issues. How is it evaluated and what's the outlook?
Evaluation is triggered by finding a single measurement 3SD below the mean, or seeing the head circumference progressively falling away from the normal curves. A detailed history, prenatal exposures, birth history, development, and thorough physical and neurological exam, including measuring parents' heads, are crucial. Neuroimaging is often needed to look for structural abnormalities or signs of injury. The prognosis for microcephaly depends heavily on the underlying cause. Some genetic forms might be associated with relatively mild developmental issues, while microcephaly resulting from a severe brain injury often carries a much poorer prognosis for cognitive and motor development.
That makes sense. The cause dictates the outcome. Lastly, you mentioned craniosynostosis, the premature fusion of skull sutures. How does that affect head shape and potentially development?
Craniosynostosis is specifically the premature fusion of one or more of the fibrous joints, sutures, between the different skull bones. Normally, these sutures stay open in infancy and early childhood to allow the rapidly growing brain to expand. If a suture fuses too early, it stops the skull from expanding in the direction perpendicular to that fused suture. To compensate, the skull will grow more in the directions parallel to the fused suture, leading to an abnormal head shape.
Can you give examples of those shapes?
Sure. If the sagittal suture, running front to back along the top of the skull, fuses prematurely, the head becomes long and narrow, a shape called scaphocephaly or dolichocephaly. If one of the coronal sutures, running side to side towards the front, fuses early, it causes flattening of the forehead on that side, called anterior plagiocephaly. Fusion of the metopic suture down the middle of the forehead leads to a triangular-shaped forehead called trigonocephaly. If multiple sutures fuse prematurely, more complex and severe deformities can result, sometimes restricting overall brain growth and potentially leading to increased pressure inside the skull. Certain patterns are associated with specific genetic syndromes, like Apert syndrome or Cruzon syndrome, which involve craniosynostosis, along with other characteristic facial and sometimes limb abnormalities.
It sounds like early diagnosis and management would be important there.
Yes, depending on the type and severity, surgical intervention might be needed to release the fused suture, reshape the skull, and allow for normal brain growth, as well as for cosmetic reasons.
Wow. Looking at head size and shape really opens up another complex dimension of growth and development, highlighting how structure and function are so intimately linked right from the start. The detail is incredible. Well, we've covered an immense amount of ground today. A truly monumental deep dive into the fascinating, intricate world of child growth and development. We journeyed from the microscopic level of cell multiplication and differentiation right up to the macroscopic measurements of height, weight, and head circumference. We explored that complex dance between genetic inheritance and environmental influences, starting from conception all the way through adolescence. And we delved into the significant challenges that arise when growth goes awry, looking closely at short stature, failure to thrive, and the complexities surrounding head size and shape abnormalities. It's been quite a journey.
It really has. And I think as you reflect on all this detail, the key takeaway isn't just memorizing definitions or milestones. It's about truly appreciating the profound interconnectedness of it all. How genetics, nutrition, hormones, infections, social factors, emotional well-being, how they all weave together to shape a child's physical trajectory. And remembering concepts like the Dio-Head hypothesis, that what happens in these early critical periods has implications that echo throughout the entire lifespan. It really emphasizes the lifelong importance of optimizing growth and development right from the start.
Absolutely. That interconnectedness and the long-term impact really stand out. So as you, our listeners, reflect on this deep dive, maybe consider this: how many of these incredibly complex factors shaping a child's growth are actually within our control, whether as individuals, as families, or as a society? What does this truly comprehensive understanding of growth and development tell you about what it really means to nurture the next generation? It goes so far beyond just providing basic food and shelter, doesn't it? It truly is a symphony of influences, where every single note, every nutrient, every interaction, every environmental exposure, every bit of emotional security really matters in composing the lifelong melody of health and well-being.